Years.
First, I want to thank the organization. For the invite, and the Red Cross School too. I'm here representing the Portuguese Institute of Rheumatology in our role that podiatry has for 18 years. The Portuguese Institute started in 48 as the Association of Rheumatology. Then in 52, the first rheumatology consultation was created by Dr. Assunção Teixeira. Then the Association of Rheumatology is renamed the Portuguese Institute of Rheumatology. The Portuguese Institute is one of the oldest institutions dedicated exclusively to the treatment and monitoring of rheumatic patients. It's focused on the diagnosis and follow-up of patients with rheumatic pathologies and has a strong tradition in pre- and postgraduate training. At the institute, that the specialty of rheumatology was born in Portugal, and where the first rheumatologist interns were trained. The Portuguese Institute of Rheumatology is a private institution of social solidarity. It's a non-profit, but works with the national health system. Currently, it has 33 rheumatologists, 3 interns, 3 physiatrists, 2 nutritionists, 2 podiatrists, 6 nurses, 6 physiotherapists, and an inpatient unit with 15 beds for internament, hospitalization, a day hospital, and an ultrasound center recognized by the European Alliance of Associations for Rheumatology. The day hospital monitors patients who regularly undergo biotechnological intravenous therapies and patients undergoing subcutaneous biotechnological procedures on an outpatient basis. The day hospital also supports the clinical trial units and the clinical research center. The rheumatology podiatry consultation was created in 2015 with 1 podiatrist at the time, my colleague Cristina Carvalho, initially for inpatients and later for outpatient consultation. Since 2013, there are 2 podiatrists, my colleague and I, and since 2019, the podiatry consultation was able to be integrated in the National Health Service in the institution, the Portuguese Institute of Rheumatology. In our consultations, we see between 2,500 and 2,800 patients annually, having in mind that both of us are only part-times. In Portugal, rheumatic diseases have a prevalence of 56%. 40 to 60% of situations of prolonged physical disability and loss of autonomy. 43% of rheumatic patients have missed work days. 35 to 41% of early retirement are due to illness. And early retirement due to rheumatic diseases cost more than 900 million euros per year. Rheumatic and musculoskeletal diseases belong to the group of autoimmune diseases which are characterized by deregulating of the immune system, causing to react against the body itself and attack healthy tissues and organisms, which cause pain, inflammation, and severe deformations and organic lesions in the individuals. The main manifestations in rheumatoid foot that we see that our doctors reference us to are hálito valgus, pes planus, cavus, hyperkeratosis, chlorohamartose, metatarsalgias, plantar fasciitis, peroneal tibial tendinitis, Morton's neuroma, Filth valgus, joint stiffness, swelling, change in the foot, dactylitis, how it works in the Portuguese Institute, that the general practitioner asks for a specialty consultation. They go to the institute, then they are seen by the rheumatologist, and the rheumatologist then refer to us depending on what they think. Here is a study that was made in another hospital that shows the main manifestations that were seen there were like ours. This study shows that 13% of patients with RA have foot involvement as the first sign of RA, and 90% will have foot manifestations at some point of the course of the disease. And the sites of the symptoms are mostly to be in the ankle, 36%, forefoot, 30%, and hindfoot, 17%, and midfoot, 7%. So you can see that sometimes the first signs of a disease is in the foot. Here are some of the examples of the metatarsal heads, hallux valgus, deformities that we see in our practice. Our role in the Institute is the reduction of foot-related pain, maintain and improve foot function, maintain or improve mobility, improve skin conditions, treat callus, corns, do the nail care, patient advisement and education, to do orthoses and insoles, footwear review, and reference and work together with other specialties. Work with the rheumatologist, with the physiotherapy team, with the nutritionist. The weight loss is important for the foot health. And sometimes, because we can't see them all, we have to send them to their health service, so the nurses can help with if they have wounds or they need extra examinations that we can't provide directly, or will take too long to ask the rheumatologist than to have it. So sometimes it's easier to go to the medical practitioner to get the exams faster so we can diagnose and treat the patient. We see a lot of tenosynovitis or in the consultation, and the rheumatologist sends us a lot of these patients. Because of the tenosynovitis, there's going to be a flattening of the foot, what provokes chronic inflammation that can involve from tenosynovitis to tendinosis, even leading to rupture and causing the overload of the stabilizing ligaments in the hindfoot, leading to the flat foot. We normally use insoles in our practice that has an encapsulated heel, and with a gradual control of pronation and abduction of the foot. Of course, in the association with the medication and the therapies they are already doing. The steroids, the biotechnological medication, the mesotherapy they do, the muscular strengthening, the whatever they're doing. Here are some examples of the people with tenosynovitis problems. We see a lot of problems depending on the disease. When it's more psoriatic arthritis, we see more enthesitis than synovitis. It's one of the signs that help differentiate. In the first stages, they're trying to discover what the patient has. You can sometimes look at where the problem is on the foot that can help to get to an easier diagnostics by the rheumatology. Here are some of the work that we have, our insoles, having in mind that we are underfunded and our budget is very low, and sometimes me and my colleague have to pay for some things so we can do a better treatment for our patients. These two studies were to show that there's not a consensus on which type of insoles to use in an example of rheumatoid arthritis, if a soft material or if a semi-rigid. We play with both. It depends on how the patient is, in which stage of the sickness he is, and if he has other sicknesses associated. When a patient has RA and fibromyalgia, it's complicated because they can have different crises at different times, and sometimes they can use the insole, sometimes they can use the insole, sometimes we have to do a new plan altogether. Subluxation of the metatarsal joints is another reason that we see a lot of patients. That results on the overload of the metatarsal heads that result in hammer-toe deformities, and that can progress to capsule-like injuries, even plantar pressure ruptures. We initially normally use silicone orthosis to stabilize the deformity, and then we use these primarily because most people have difficulties to tolerate rigid material or even insoles. Ulcerations. The ulcerations that we see normally are on the top and tip of the fingers, the metatarsal heads, the first metatarsal head associated with hallux valgus, and interdigital spaces due to friction. There is little research in the area of ulcers and rheumatoid diseases when compared to diabetes. Although we know that RA ulcerations has a lower risk of amputation than compared with the diabetics, but they still cause pain and impact of life, and footwear choices are difficult. This study was a primarily investigation that concluded that that deformities and the increase of plantar pressure were not associated with the risk of ulceration, but with the active disease and the steroid therapy. They concluded that the disease itself and other disease associated and the steroid therapy were had a more direct link to the increase of ulcerations than the pressure itself. Here we can see some of the ulcerations that occurred in our consultation. Various deformities that we can see. These are the orthoses. We are very creative. We do a lot of different styles, and we try a lot of things, everything that the patient feels okay, that we see that can help. Here we have another one. Here, a full protection. Here, the normal. One of our elaborate. This study was made by a medical student that found this article, that questionnaire a medical population in an Irish Institute of Internal Medicine. And they concluded that only 12.5% of the doctors felt apt to examine the foot. In our experience, initially with my colleague, most of the rheumatology doctors didn't feel apt to examine the foot, even read x-rays of the foot. Now, it's been better, but initially, it was hard. Normally, some would send them to the orthopedic before to us, but now things are getting better. Final considerations. The foot is the most frequent site of pain. It's still not given the importance that it deserves. The rheumatoid foot has the same risk of ulceration as the diabetic foot, but in terms of studies and priorities, it does not have the same impact. There are few rheumatology services that have podiatry support. In Portugal, only one service of podiatry is integrated in a rheumatology unit and covered by the NHS. So there is a need to create more multidisciplinary teams to treat rheumatoid foot and to create awareness of the rheumatoid foot. Thank you.
Thank you.